said so far is that if Africa is going to catch up and get on this highway, which most countries are already well advanced on, who have built systems that are so aggregated from clinical trials all the way to management of health systems through electronic medical filing systems in hospitals, all the way to even how we manage not just our hospitals, but also how we drive investments into healthcare. If we're going to get on that highway and catch up with those who are far ahead of us, then the quickest way to catch up is to get on the digital highway. Especially for a continent that have no roads connecting us, that have no rails connecting us, that have no ports connecting us. The only thing that could connect 1 billion people on this continent is digital. And how do we know that? By just the penetration of digital tools that are being used on the continent, whether through social media, through the internet, and even how we conduct our research and move data across the continent. By doing that, we can guarantee that we'll cut costs because it's cheaper, especially when there's already the infrastructure, the digital infrastructure in place. I mean, compare that to the road infrastructure, the rail infrastructure, the port infrastructure. The digital infrastructure is by far the cheapest and the most cost-effective. When it comes to One Health and how to expand access, again, we can rely on digital to get us there. When it comes to collecting data and also even doing testing, we do it faster by digitizing even the RDTs that we are using now. You're collecting data in real time, as opposed to waiting for people to collect the data, then send it to a location, then aggregate the data, then send it to the regional, and then eventually the national data, or if you like, the National Health Information System. Just by digitizing that RDT and programmatizing into this information how the data gets collected through the digital mechanism, you already know whether it's men, women you're looking for, whether it's people at a certain age, all of those things you can get in real time just by being able to embed or encode the tools within the digital systems that we're using. So if you take scaling and also traceability, how to track, if there's a pandemic, for example, and you want to trace where the onset of the pandemic is all the way, through just those digital tools, much faster and better. So when you look at the principles of digital health transformation for any public health infrastructure, digitization or digital tools underpin cross-cutting across every aspect of it, whether it's universal connectivity, where the infrastructure is in place, whether it's on the digital goods that we offer, whether it's electronic medical health records, whether it's even the various points of care diagnosis, how you collect that data. But now if the patient has to now leave and try to find medications, for example, from a pharmacy, you need to be able to get on a tool to know even whether the pharmacy I'm trying to get to has that medication. Can be maximized effectively by just digital intervention. Before going to queue and go there and you are told that the medicine doesn't exist, so you have to go to another hospital. Or if you're trying to rush a patient to a hospital, try to even know whether there's bed availability. All of these things can be programmatized into tools where at the touch of button you can know. It's a lot of cost. So a lot of these digital tools, whether it's e-health or even telemedicine, all of these things can be impacted upon just by having universal connectivity. And then once you come to things like inclusive digital health, information security, that's where data becomes very important, how this data is protected. So you realize that right from health, you're moving into economics, moving into national security or data security, you're moving into even regulatory, all because all of the various digital systems in the various institutions are connected through a highway. And through interoperability standards that make the API connectivity seamless so that the individual, whether it's the point of care diagnostician, the community healthcare worker, don't have to do a lot of work thinking about the processes because the processes themselves, through the tools that are embedded, continue to update themselves. And so you don't make any mistakes because you don't move on to the next level until you fulfill the requirements that you're supposed to fulfill. And then when you add AI to it, it takes it to a little level. This slide just talks a little bit about the penetration of internet usage, or if you like, mobile penetration across the continent. And you can see, giving examples here for Algeria, Kenya, Population in Algeria is 43 million. It's 117 penetration of mobile users. 58 penetration of internet users. Meaning that at least 1 in 2 people, or in some cases, 1 in 3 people in Algeria, one person has at least 3 cell phones. Or the mobile phone for so many things that makes it look like there are 3 people using the mobile phone that 1 person is using. Same in Morocco. You take Cote d'Ivoire, which have 120 percentage penetration mobile users, 44% of people on the internet. So twice the population of Ivorians are on the internet almost daily. And then if you look at the social media penetration, the cell phone penetration usage, you see that at least each individual is carrying at least 2 phones. Okay? So what you do with that cell phone when it comes to health, and the question becomes, what are they using those phones for? They're using it for many other aspects of their social intervention. They're doing it for that. Why not asset property we have, which is health? What is $1 billion graveyard if you're not healthy? So if we're using cell phones for how we pay money, we make mobile social life, how we do all manner of things in our social mores with technology. The most important thing, primordial thing that we have, which is our health, because the most valuable thing we have on the planet is our lives. And one of the things that contributes to that life is health. Okay, so internet penetration differs across the continent, but what is clear is across the continent. A lot of people are using cell phones. So how we embed health, public health, trials, data collection for health, all of those things into that cell phone, that does not get them deviating from what they do socially, can impact upon health massively. And as I move further along, the question becomes, how do we systemize, standardize, and be able to replicate these models at community levels, country levels, and eventually at the continental level, and get Africa competing at the world level? We know that out of all the genomic data that exists out there, especially when it comes to genomics, Africa is the least sequenced of genomes, and yet we have the most diversity of genes, genetic pool. Being able to use big data now to acquire and sequence our data has massive impact on how manufacturing of medicines will take place in the world. And if Big Pharma realizes that we have access to that data, a lot of those pharmacies will move here, and then we can now move into more precision and customized medicine just simply because of the investments we make in digitization of healthcare. So situational analysis in terms of how we collate and data on most of the diseases that are prevalent now, whether it's HIV, diabetes, respiratory diseases, which sits on the health side divide. Then we come into the social drivers, things like economic, socio-economic, environmental, geopolitical aspects, which sits on various divides, but also impact on health. Then you look at the inequality context, which talks about the cultural drivers. Prioritization of where we should apply resources. So if I'm a minister of finance, and I want to now make decisions on how I allocate budgets, these digital systems now are able to help me understand where I can make impact. So I'm not parking health to the back of the bus as something we come to, but realizing that actually you cannot have a successful and a wealthy economy without a healthy, productive workforce. And if that economy, which is mostly youthful, are going to be economically productive, then we're not going to be burning a lot of our cash buying malaria medicines for them. Because if we look at how much we're spending on these medications and not even adding all the social elements, bed nets, all of those things, a lot of that, if we invested into preventive care, could save us a lot more money, and we don't have to go borrowing money. You know what? So these are the kind of things that digital tools can help us prioritize, identify solutions that are innovative and optimal, and then now be able to embed e-health solutions into things actually more sustainable and feasible and sustainable. And then, of course, from a policy standpoint, it also helps us know where to direct resources for investments as well. I'll start concluding by talking about what we're doing in Africa CDC now to make this easy and accessible so that each country doesn't have to be doing this work. by the building, the regional data centers and infrastructure we are building. Lessons that we are learning from Ghana, instead of countries like Liberia and Sierra Leone going to other countries to look for investors or look for support to come and run those same programs, they can learn from Ghana because that data is available. Those lessons can be learned and can be shared. So we call what we're doing the 4D system for embedding biosecurity, screening, and biosurveillance protocols with digital infrastructure and tools that can either go into what we call shallow penetration or deep penetration, depending on what the country has. So if the country already has digital systems they are deploying for research and development, for clinical trials, for example, then what we do is we build widgets to connect them to what other countries are doing in similar domains. And then we can cross-share data. But if the country doesn't have the infrastructure, they don't have to go invest in the infrastructure. They can use the Africa CDC infrastructure to do a lot of this work so that each country doesn't have to go trying to invest in some of these things. I'll give two quick examples and I'll close. So during the pandemic, Africa CDC developed what we call the Pan-African Biosurveillance System. The surveillance system took into account that countries have their own labs, countries have their own health systems, countries have their own national repositories for healthcare. But what Ghana is doing has no impact on what Nigeria is doing, because even though we have similar labs, especially the private labs and even in the reference labs, when somebody does a test in Nigeria and comes to Ghana, we have no way of knowing whether that test was printed on his laptop, whether he did the test, and whether when he said it was negative, it was actually negative. The only way you can verify that is to have a digital system that can query the database of that particular place where the person took the test and be able to confirm that that test actually happened. It was, even though they may have similar, his fingerprints or whatever proves that this is the actual person. So this is one way of making sure that we have biosecurity standards that can be respected and adopted. So PanaBios was developed with that in mind. And what did we do? We were, with that, because remember, we traveled during those periods, right? So just by being able to use digital tools, we're able to get the countries that onboarded, and one of those countries that signed up. We were able to register the admins, the public health admins. In the case of Ghana, it was the director of public health. He was able to now get into the system. They were able to train all the lab heads. We're able to now get all of the lab technicians in each lab that join the platform credentials within which they upload the digital certificates for patients who tested for COVID in those labs. Of course, the UHAS system, which is the National Digital Health System, had that data. But that data now we were able to connect it to a digital highway connector. So if tests were done in Uganda, you needed to board a flight. Remember, there were so many protocols then. We're talking about things like PC test as the standard, testing for COVID at the time. Those who were doing all kinds of other tests, the antigen test, those who were doing antibody tests and things like that. Different countries have different protocols. And then different countries had also protocols around how many incubation period they needed. So if, for example, you tested in Ghana and you wanted to go to Rwanda, Rwanda requires a 48-hour test result for COVID. But other countries wanted 72. A test done in a day. So are you going to keep going into each country, look at the website to see what their protocols are, and then go to the next country, go through 3-4 countries? Whereas once you use standardized tests, if you test in Belgium and you wanted to travel to France, the test from Belgium, you could take it to France. You go to cross-border. If you did a test in Atlanta and you wanted to go to California in the US, same tests were standardized. But when you did a test in Togo, in Lancet, and you wanted to come to Ghana, you had to repeat the test in Ghana before you go to some tests within the same incubation period. Absolutely no sense, right? Part of this problem was that the regulatory systems were not standardized. And so being able to build a digital system that connected what was happening in countries, and without interfering with their data processes, but being able to just verify whether these tests actually happen, kind of example of a digital highway. I'm talking about. That makes you globally competitive. Because otherwise, Africa keeps moving back to the back of the bus, even though we have abilities, we have the digital tools, but our fragmentation and ability to join a highway makes it able for us to contribute to digital global standard. So we found a situation where in 22 countries where we were able to integrate countries into this digital platform called Panabios. We are now integrated labs, we had integrated port health, we had integrated genomic centers. In fact, we started connecting genomic centers just before the pandemic ended, but we begin to build on top of that. So where diseases are coming from, somebody bought a flight from India, tests in a lab. He flies into the continent, he goes into Ethiopia, he gets on Ethiopian Airlines, he flies into another. How do you even begin to trace and track who he sat through next to the plane? So by being able to connect airlines, by being able to connect labs, by being able to now connect country protocols and embed all of these things into the software, if I upload my test certificate, it runs a compliance check very quickly to see if I meet the requirements of that country. And if the country requires a 48-hour test and I have a 72-hour test, if the country requires a hepatitis test in addition, all of these things will flag, and then it will require me to upload the hepatitis test or upload a test. If I don't meet the requirements of that country, I don't even bother to go to the airline at all, because the airline operators cannot tell the difference between a PHC test or an antigen test. They don't know. So all they know is a piece of paper you hand over to them. That doesn't guarantee biosecurity. So these are some of the elements that make it possible for us to have a very, very standardized system by getting into a digital highway. End of the pandemic, we had digitized lab registries from 35 African countries. We had end-to-end deployment done in 22 countries, with 12 more that have joined since then. We had 7 labs and clinics in Africa. We had onboarded 25 countries on 4 continents outside of Africa digitized, including Australia, India, had all onboarded. Why? Because the policy at the time was that you couldn't come into the country if you didn't have a test certificate verified, depending on the country's protocol. So India, China, all of these countries who had people coming into the continent were compelled to now onboard their digital test certificates. What the AI machine algorithms were doing now was studying the various features of all these lab certificates across the continent, because their labs were not physically onboarded. And we're able to tell whether those lab certificates were fake, were genuine, whether they came from. So it minimized a lot of the incursions of diseases coming into the country simply because of these digital tools that we put in place. We had 4 protocols program, like among others, and major airlines had integrated into the platform. And there were over 20 as of now African beneficiaries of this digital tool. We are now evolving it into vaccines. And what the amazing thing about this is that once you have test data, you have that vaccine data, you have genomic data. Genomic data helps you understand how variants are coming into the continent, where they are coming from. There's so many things you can start learning from this. Whether somebody tested positive or negative, took the vaccine and still tested positive. How we even know whether the immunity thresholds are boosters or don't need boosters. All of these things now you can do because you have the data. And you don't have the data just for one country, you have it for multiple countries across board. So test data, vaccine data, genomic data, travel data, all of these things that were sitting normally in different aggregates. Now through a digital highway, we had all this data, and we're now contributing to global standards. Africa actually became the very country that was actually doing digital verification at the first continent, the only continent that was doing actual verification of COVID vaccine certificates and test certificates. We're ahead of any other country. The European Union, even though they had the EU DC standards, you couldn't go to borders during the pandemic and see a digital verification of certificates. So that's something we needed to be proud of. And that, for me, should now evolve beyond the institutions that have been disguised, the labs that have been digitized, to individuals who now must carry on their phone their digital health wallet. And what does that mean? Having a digital wallet simply means that you now have control of your data. If you travel across regions, you go into the Western region from the Volta region, and you saw a doctor, you don't have to go looking for your last test certificates or trying to be calling to see if somebody can find it and send to you. All of these things can be at the touch of your phone, and you can now give the permission to your doctor to assess it and be able to make decisions on health based on your history, your clinical history, and your test data. But this could also evolve. Imagine across the continent, everybody having a digital health wallet. Now you determine which doctor you go to for for second or third opinion based on the data you have. And also, because now all of the doctors, nurses, caregivers are also onboarded on the platform, you have to determine where you want to go for your health intervention. And it could be virtually done. And then you can now go to a health facility post. So the vision of, now that we're collecting a lot of data on test data, genomic data, among others, and we have visibility on what is happening across the continent on the highway, the next task is to begin to work with countries to onboard citizens onto the to have their own digital health wallet. Because that has implications on demographics, it has implications on economics, it has implications on spending, and also where we even allocate resources, healthcare. Whilst that is happening on goods, because remember again, the vision of the African Union, or member states, or assembly of heads of states, is to create an Africa where we have free movement of people and goods. For us to have a common market and become globally competitive. You can move freely in Europe, you can move freely in America, you can move freely in Asia, you can move freely in Africa. Part of it is because of the health implications, disease burden, among others. And it's a cost driver than a preventive driver. So whilst we're doing this work in the area of free movement of people, so that digital health wallet now should be able to cross the border with the protocols of countries embedded. If I'm coming from a country that has Ebola, when I show up at the port health, because all the various systems and standards are integrated, we know that you were actually in Congo yesterday. You came from a region that has a high incidence of Ebola. So when you're in the queue, we can set you aside and do further tests before we let you in the country, simply by just being able to access your health. But how about goods? People cannot move. Goods cannot move without people. So currently we are working on what we call PROPER, the Proof of Origin Platform for Electronic Registry, which Ghana's FDA has already onboarded, and many Kenya and many other countries have onboarded, which is a traceability mechanism to trace goods across the continent that are coming to a continent, track and trace mechanisms. Okay? None of this again can be done without digital. Now, when all of this is said and done, what we would have ended up doing is to create a digital health ecosystem where the foundation is owned by government, meaning the data is owned by government. So our data are not sitting anymore in philanthropic institutions across over the world, and then they are coming back to tell us where we need to be spending our money because the data now belongs to us. That's a great asset. In fact, it's actually more valuable than gold and diamonds. Okay? But then once you do that, the huge innovation community we have, all our young people coming out who are digitally inclined, innovation inclined, can now build on this ecosystem, whether from a standpoint of insurance, whether from mobile applications. I mean, you look at the amount of money that is spent in training and providing support for AI, artificial intelligence support, whether it's by Gates Foundation or others. There's a lot of innovations happening. But there's no uptake of those innovations within our health infrastructure in the continent. At the last year's health challenge that was launched by Gates Foundation, out of the 1,200 people that applied, 80% of the applications were Africans. Out of that 80, the top winners, 50 of the top winners, which was about 60, were all Africans. But where are those Africans? They find themselves back into Google, find themselves back into working for global companies. But they've innovated so many amazing things with their award money, but we don't see those innovations in our healthcare systems. We don't see them being used in our tertiary institutions or in our facilities. We don't even know they exist, right? So having a digital system, a digital highway, gets us visibility. And these innovators now are able to, we saw what happened with how companies were able to innovate and create the mRNA vaccine way ahead of some of the institutionalized pharma companies that existed, simply because of the ability to be able to harness and assess, analyze big data. So this is exactly what we are looking at with this digital highway, is to be able to create a kind of infrastructure that enables everybody to become part of a health ecosystem that contributes data to creating a highway that eventually minimizes cost. Possible for us using artificial intelligence to do real-time diagnosis, interventions, and social interventions. So by saying that I have speed no longer tolerated, poised, but the question is just ready. because it requires see some kind of, but we don't know where people forms on. So being able to get with the program, get systems in place. What we should be concerned about is what cybersecurity protocols are we putting in place to make sure that we're not losing this data. Those are the things we should, as opposed to whether, oh, where's our data going to sit? Because the impression is being created that we're going to be making money off our data. And whilst we are doing that and fighting among ourselves, other countries are leaving us behind on the highway. So it's time for us to get on the highway and get into the data. But get your seatbelts ready. Enjoy the ride. Thank you very much. Thank you. Thank you very much.
A very interesting and insightful lecture. Can we do it for him again? And try and make some time because of the information we had just at the beginning of activities. Let's see by hand. Only a few questions. 1, 2, 4. Is that right? Okay. So we have 4. So we'll start with 1, 2, 3, and 4. Let's finish with this one.
Thank you very much, Adam. Very, very stimulating. Very, very, very interesting. As I listened, and as dean of a school of pharmacy, I was thinking about my students, but who are in the, where do we, what they call it? I'm looking at, and I've also viewed various curricula. This discussion has been around for some time, AI, digital solutions, and all of that. The question is, how much of this do we have in our training programs? Do we expose them, and how? So on this, as I was reflecting, I wanted to a workshop, a training workshop. I mean, for all the students in the professional years, we are University of Health and other sciences, so nursing, medicine, basic sciences, and all of that, public health. All the students in the professional, years of their study and the graduates run a training workshop solutions for her, at least as a starter, and look at the curriculum. Informatics, but even that one, I haven't seen. But this is kind of a revolution which is coming. I don't think we can be left behind. Thank you.
Thank you very much for the presentation. It was very informative. So I got from the presentation, there's a lot of digitalization and innovation in Africa, but we are not aware of all this that's happening. So I wanted to ask, how can you make this information to Africans if they did not come for research conferences like this? Because I was here and I was just amazed that all this is in Africa and I was not aware. Thank you very much.
Thank you very much for the presentation. I want to find out, so beyond the strong digital systems, what can nations do, or what other systems must be put in place to ensure that various countries accept whatever people are bringing from elsewhere? So I'm taking an example like when somebody is coming from UK, COVID time, with a PCR test, is getting to Ghana, he's supposed to do an antigen test. So what other systems are we, because Ghana needs money, what other systems are we going to put in place to ensure that some of these things are enforced? And secondly, how far away or how close are we to having a digital wallet? As I stand here, how far away am I from to get a digital wallet? Thank you very much.
And then
I hope I can sit down and talk. Okay. Adam, thanks very much. I missed the beginning, but I really enjoyed what I heard. I just wanted you to enlighten about data security. In other words, you can have data in the wrong hands if you are not very careful. In my research career, it's been my phobia. Data, to make sure that I keep it as my data. I'll publish it, but not to let it to everybody what they like. Our colleagues are smarter than us. So if you are not careful and your data gets into, you publish it and then you will be struggling because our internet is not good. Our systems are not even getting statistical support, which I will need for most of my down. I'm concerned about that. Now we are going digital. Now we want to find the data. Very whole thing. Going to a doctor, maybe giving some leads, and then the doctor has your profile, everything is able to tell you, give you diagnosis. Very, but that data, that without consent from you. I think if you can, maybe not in this discussion, but for me, that's my concern.
Thank you very much, and these are very stimulating questions. I'll start with the question or the comment about the training programs, which I think is extremely important, and which is why I applaud the UHAS for sort of inviting some of us to sort of partake in some of these discussions, because for us, it really, really boils down to training and education. The kind of training programs that we're talking about now has to be customized and targeted towards the area of working endeavor. So I'm in pharmacy, for example. Like it or not, digital tools are going to revolutionize how we do it. They already revolutionized how we even do surgeries. In fact, most people now would normally turn to the internet information than they will call their doctor, right? So for a country that has one doctor to 15, 12,000 people in the city, one doctor to 40,000 community, most people will probably never see a specialist if they lived in a rural community. But if they have access to a phone, if they are not speaking to a relative about their health condition, in fact, the most relatives they'll speak to, most take their basic information, Google, and then try to even start doing diagnosis before you ever even hear of a pharmacist. In fact, when they show up at a pharmacist, it's to tell the pharmacist that this is the medication I want, as opposed to, because this is what I think is wrong with me. I've even probably spoken to a doctor, right? I think the training has to encompass not training in, understanding nomenclature, medicines, and all of those things, and treatment. Remember when I was in my 4th year in med school when we were doing pharmacology, we learned about so many drugs, their uses, by the time I began to practice, a significant number of those medicines didn't. And even if they exist, drugs that were coming, that we had to be learning on the job, right? And people coming to you with flyers and telling you what these medications could do and things like that. When do doctors have to do even try to see if the patients that they're doing? That's where the training comes in. And that training requires things as basic as training you use in standardized trials, steps in our curriculum, various elements of digital tools, digital training should be introduced and must be introduced. to ensure that we are also enriching not just the information awareness is there, but also how we are using digital to also improve on how the pedagogy around pharmacology as well. So my answer to that question is simply customized, targeted, not having a whole curriculum on its own, but having each aspect of the curriculum being impacted on by some kind of digital knowledge. In this case, because that machine learning tool to give you more information by just getting a lot of aggregated data. So that would be my answer to that question. And I look forward to more of these engagements where we can actually run workshops and run programs around digital health as it relates to pharmacology. And given that a lot of the interventions we are making is to make the lives of patients better, we should also use this as tools as also taking from patients as well to improve how we serve them better. When it comes to the question about awareness, a lot of things are happening, but we're not aware. The answer is correct. You are right that which is why again platforms like this are going to be very important. All of these has intensified the awareness. Also, targeting universities and research institutions, because it is knowledge that comes out of these institutions that influence and direct how people and what people and what we also. Today we see there's a break between what we pursue, where we purchase, what becomes trendy. I mean, if you look, follow that will hear music or some joke or something on the internet and go and view it, versus those who will view something that has direct impact on their health. Notice that most people pay attention to some jokes somebody created, some silly funny thing that somebody posted, and will have 2 million views. And yet something as important about what we're eating, how we are eating, how it impacts our health, water we're drinking, all of these things, the environmental intelligence, a lot of it is how we package the information and communicate it. So if we can get more communicators, people who are experts in communication, because most of the time it's us amongst ourselves. We know, but how do we communicate so that more and more people know about these things? And that's why I think we should. There's no reason why it's for nothing that Coca-Cola, as well advertised as it is, still invests a lot of its adverts, right? Its budget to come simply because they want to communicate that Coca-Cola becomes part of it. The little baby, by the time he reaches out, if you give him a choice between Coca-Cola or whatever, he picks Coca-Cola. Because it's already programmatized in DNA based on just information he hears about it. So we are communicating. That's what I was saying. And today, the quickest way of communication is through social media. And if we can package the information and not make it so long and wordy and giving a lot of information that is and package it in a way that it can communicate better. I think that will be the quickest way. Just for brand recall, when people now get the awareness, then they will now come to you for more information to precipitate action. Where do I go? Where do I buy it? How do I assess it? How do I know? But the initial part is to how to get people to have brand recall, how to be able to get interested in the information. And I think we should be working more with communicators on that. When it comes to the wallet and standards, I guess the answer to that is that it's a lot of work that would need to be done to get countries to the minimum that it will require for us to be able to operationalize the use, starting with even within the country. As we travel across the country, being able to port our information. But we are doing that with SIM card interoperability. We can decide that I want to move from Telecel now to MTN and things like that. I should be able to port my health information, but you can't without a tool. And so we have to look at technology as a tool. At the end of the day, policies that are going to and eliminate the fact that there will be people who use it for all kinds of nefarious reasons. But it shouldn't be the reason why we don't get ahead of these things. It means that we just have to build stronger standards, security standards into these things. So as far as the standards aspect is concerned, I'll conclude by saying that standards on their own don't implement themselves. All the WHO guidelines that are being put there, sometimes they're so voluminous, and now with AI tools, now some of those into 3 pages and things like that. It's just standards that sit and don't implement themselves. We have to implement it. The question now is, does Africa continue to sit and wait for standards developed elsewhere to be imposed on us? We ourselves need to be contributors to those standards. The only way we can start contributing to those standards meaningfully is being able to have data. And if we're not collecting the data, and it doesn't cost to collect the data. So for the earliest introduction of digital tools is just use data collection. And if we start collecting the data and analyzing the data, and when we sit at the table, we are seen more as contributors to standards as opposed to recipients. Because we say this standard doesn't apply. The standards learn itself around, as we say, agroniform. And then finally, there was a question about, from Prof about data protection, which is a very important question because that's where a lot of the pushback is. And my answer to that concern is that yes, where the work resides is the security measures we embed into these things. So we look at how we transact today. I'm sure the first time somebody came up and said, oh, we can use a card to transact business. You can go in, you can withdraw money, but we keep the card. We don't share our PIN word or whatever, right? But then we now move into digital money, where we can now do Momo and all of these things. Is there fraud? Absolutely. People are able to find ways of hacking and stealing money and things like that, whether it's in e-commerce or e-trade, e-money. Business and things that are so vital to us like money. So it shouldn't be too hard to apply the same security protocols wherever they exist. If the banking institution has found ways of investing into the highest standards of security protocols to protect people's money, there should be a high standards of security protocols to protect the most valuable aspects of our life, which is our health. Okay. Then when it comes to intellectual health, when it comes to research and all of these things, it requires being able to have the biosecurity systems to ensure that one, we are changing our passwords often, two, we are improving the cybersecurity protocols, and many other things that could be done to ensure that no one is stealing your. All of this again has implications on governance, right? If it's what we prioritize and how much we invest into it is what is going to give us the protection. So a lot of the skepticism is justified simply because if you look at laws that exist, for example, how does it really, are they just laws that others have done that we want to copy and paste? How are we operationalizing these laws in our day-to-day? So that we know that, no, there are gaps in these laws, there are gaps in these tools, we should improve it. And then when the practitioners of these cybersecurity standards, or if you like, security protocols, how involved are they in the kinds of things we're doing, whether it's digital money, digital health, because everything is becoming digital, e-education, e-regulation. So I think that's where, and the more intellectuals or people among the intelligentsia that gets more involved, as opposed to being more skeptical, the pressure comes on our policymakers to ensure that not only the policies that govern these laws, but the that need to go into making sure that these laws do work are taken seriously. Because again, only by using these tools can we scale quickly and become also visible to the world. And to my brother said earlier, there's a lot of things happening, but we're not visible to the world. And part of the reason is because we're not on the digital highway. Thank you.
Colleagues, time is not on our side. We have spent the time, so please bear with us. So, without a doubt, digitalization will continue to affect us and will continue to change the way we do things. And so let us all get involved. Let's use it and make sure that as we use them, um, things get better and better for us. One of the things that I'm taking home is thinking of getting my health wallet. I think all of us should be thinking about that. If you can go to a place and you can just get the up, get all the information you have for your things to be done for you, I think that will take us to places. On this note, let me thank all of you for paying attention to us, and especially to Adam for this delivery. Thank you very much.
All right, thank you very much. Ladies and gentlemen, we have in our presence the Vice Chancellor for the whole Technical University, Professor Kwashi Honyanuga. Shall we please? Thank you. So, Prof, you're welcome. We were informed that you'll be coming, and so we've made space for you to give us a few words. So, please come and give us a few words. Thank you very much.
Thank you very much. Because of time, I would like to proceed on the protocol already established. And I would say, distinguished ladies and gentlemen, thank you for inviting me to make a statement at the UHAS Research Conference 2024. You greetings from the whole Technical University, from the management faculty, staff and students. First of all, let me apologize that I couldn't join you yesterday. It was due to some other hiccups. I was at the Vice Chancellors of Technical Universities meeting in Koforidua, and since UHAS is a second home for Technical University, I deem it exciting to be with you this morning, and also to state that the team transforming health systems to achieve universal coverage in Africa is up and topical. It continues to live with us, and it aligns with the post-COVID explorations and solutions to the myriad of challenges faced with health delivery in Africa. That resonates a question I was asked by a friend of mine called Angela as far back in 2009 when I was studying in the Netherlands. Good, she said, Ben, I heard that in your country people die at 60 years or before they attain 60 years. Do you smoke so much? I answered and added, I don't have the data, but the percentage of smokers in Ghana was negligible. He said, do you people drink heavily? I said, I don't think so. Compared to what I've seen here, the drinkers I've seen here, I don't think people drink so heavily in Ghana. Then he quickly returned and said, Ben, I know the answer. It is because your health system is not good. As I reflect on this, as we were, then an ambulance was speeding on the road with, of course, a loud siren. And I asked Angela, I guess someone's life is at risk. She laughed and said, Ben, permit me, I want to smoke a stick of cigarettes outside. She went there. After the cigarette, she came back still smiling and said, Ben, you don't understand Dutch. The ambulance that just passed is for dogs. Someone's dog's life is at risk. It is true. So in the Netherlands, ambulance convey which need medical care. And this is a true story. He told me that conveying the dog to a referral veterinary clinic. Then the conversation went on. Said, dogs, not only dogs, we have ambulance for all kinds of pets. And we have clinics and also referral places for these pets, because these pets play very significant roles in the life of people in the Netherlands. The next question from her to me was that, do you have ambulance system in your country? I'm talking about 2000, and you can guess my answer. Because as a teenager, the first time I saw ambulance in my village was when a soldier died and 37 hospital conveyed the corpse to my village, and they wrote on it ambulance, and with the siren we all went to see. Ladies and gentlemen, indeed, our health system needs transformation. It is getting better by the day, but we need a revolution to transform, to achieve quality universality. From what I've just heard from Dr. Edem, it means that we need to approach this from multiple solution perspectives. And I'm happy that UHAS is playing this role by bringing together all the think tanks and the philosophers reflect on how we can transform our health system. Back in the village, before we had the village, I recalled we were in primary school. In a day, 9 children died. And you can imagine the number of slaps the witches will get on the day, including my son. Just because they were not exposed to having vaccination against the 6 killer disease. Today, the children don't die anymore. And the last time I went to the village, I recall this. So I asked my mother. My mother is 2 years. She still gives me soup to take. And I'm sure also, she tells me that I'm sure there are better opportunities for her to see the doctor, maybe because of us. My father died so early, maybe in her accused of killing. So I asked my mom, so the witches are no longer there? She said, but today everybody sends the child to the clinic. How will the witches play their role again? All of this goes to attest to the fact that we need to improve our health system to be able to assure ourselves. The thing that we should be talking about every day is not about this political party or that political party. How do we live? How do we improve our health system? 4 years ago, I visited Professor in the Netherlands. He told me that someone died at 60, and there's a whole committee to investigate why the lady died young. Their community, no one had died younger at that age for decades. Is it because they don't want to die? It is because they keep improving the health system by the day. And I'm encouraged by the opportunity to listen to speakers at this conference and all the efforts that you are making to expand the universality of our health system. And we in UHAS University, we are not a health training institution. We are mostly engineering and applied sciences. We're trying to reflect and see how we can support the health system through our engineering, for which we've set up a biomedical engineering department, and I'm happy to announce that we have gotten funding from Skills Initiative for Africa under the African Union and NEPA, 2 million euros to set up a center of excellence for biomedical engineering to train and also to repair biomedical engineering equipment, because we have noticed that there's a lot of gravity of biomedical equipment in our, and we want to be part of the process to train the young one and retrain, so that if we have technologies, the technologies that we turn out to be able to support also access to the universality of our health system. On this note, I'm happy to be given the opportunity to solidarize with you on this day, that you have this very important conference to debate on how we can transform and expand our health system. I thank the organizers of this conference, the Vice Chancellor and the team, Professor Mrs. Japon, for inviting me to say Aiko to you for all the things that you are doing to advance our health. Indeed, health is said to be wealth, and nobody wants to die, because I remember as a mass boy, I went to visit someone with an Italian priest. The person was 120 years old, but he said, "Father, pray for me to live long." You can imagine, so no one wants to die. And it is important to be assured every day of our health. And I want to encourage all our health workers, we should continue to work. And how to transform this health system to attain universality should be written on our hearts, as said in Jeremiah 31 verse 33, that the Lord says you write the laws in our hearts. Let's write the information processes in our hearts, in our minds, and reflect on it every day, so that collaboratively we can advance the cause of improving our system. Thank you again for inviting me, and I wish you very, very well in your deliberations. Thank you.
Thank you very much, Professor Honyanuga. So, ladies and gentlemen, we would now move to have our concurrent sessions. This morning we would have 3 concurrent sessions. Concurrent session 1, which is going to be on new technologies in health and digitalization in the health system. That will be done at the council chamber, the room down there. And we have Dr. Hubert Amu as the moderator for the session. Then the second one on scaling access, delivery, and integration of health services and goods. And that would be up on the left, the other room, that's session 2, will be moderated by Dr. Joy Akemeze. And then the third one this morning will be on maternal and child health, will be moderated by Professor Anita Fafa Date, and that will be held at the training room where you have the computers in there. So we would go now and then finish off at 11:30 for snack break. Much.